Evidence-based practice is something that you'll use all the time. Means a lot of different things to a lot of different people though, so let's talk about it. For me, there's a big difference between evidence-based practice and evidence-based guidelines. Evidence-based practice is understanding the research, but then knowing the patient and the patient's preferences and how the patient will use this information, and knowing yourself and how you can apply it and what's the best thing for your particular skills. Evidence-based guidelines seem to try to create standard practice. The problem with this is that it also can turn into eminence-based practice. Evidence is of varying levels, and unfortunately, once guidelines come out, sometimes they're then the gold standard, and if you deviate from them, you're considered to not be optimally practicing. The problem with that is that many guidelines, for example, the hypertension guidelines, JNC 8 is pretty evidence-based. The problem is that AHA and ACC decided that they were too evidence-based, and they decided that they wanted to make them a little bit more flexible and real world. Well, the problem is which guidelines do you go by? The guidelines that are the most based on research, or the ones that are then based on individual opinions of other clinicians. So the challenge, of course, is to not let the research change you in ways in which it's a negative thing. David Sackett is an expert in evidence-based practice from the early days. And he really feels like that without clinical expertise, your practice risks becoming tyrannized by evidence. For even excellent external evidence may be inapplicable to or inappropriate for an individual patient. So without current best evidence, however, practice risks becoming rapidly out of date to the detriment of patients. So again, it's a case of really knowing and understanding the research, and then using it and applying it in a particular individual situation. So that external clinical evidence informs but can never replace individual clinical expertise, and it should be this expertise that decides whether external evidence applies to the individual patient at all, and if so, how should it be integrated? An important concept that you need to really grasp when you're talking about evidence-based practice is numbers needed to treat. So this is when we take good, well-done clinical studies and we figure out, based on the numbers of people in the study, how many people had to be treated for how long to change what outcome. And so an example here is a dog bite. So many people will put every patient with a dog bite on antibiotics. This is common practice in the emergency room. The problem with that is that only about 1 out of 16 people really will become infected. Is this a rational plan? Maybe, maybe not. If you really know your patients, if you trust them, if you have a long-term relationship with them, you might be able to say, oh, okay, rather than put you on antibiotics, I want you to call at the first sign of infection and we'll get you on something. The other thing is, in regards to dog bites, was it of the face? Was it of the hands? Both of those are a bit more likely to become infected and the risk is greater. On the other hand, if it's a leg or somewhere else, the risk is lower and the risk of permanent impairment is much lower as well. A related concept is numbers needed to harm. This is how many people need to have a particular treatment to have a particularly bad outcome. So for vaccines, how many people do we need to give the vaccine to have one adverse reaction? This is important when we're looking at something like the flu vaccine. How many people do we need to give the flu vaccine to have a benefit? That's the NNT. Versus how many people will have adverse reactions? That's the NNH. A related concept is that NNTs are really based on absolute risk reduction. Absolute risk reduction is how many people actually decrease the adverse reactions or how many people actually have a bad outcome. Relative risk reduction is a percentage change. So in other words, if you have a 4% incidence of a particular problem and it decreases to 2%, that's a 50% relative risk reduction. The absolute risk reduction, though, is only 2%, and therefore the numbers needed to treat would be 50. So it's important to start understanding these concepts and start using them rather than just take what the drug companies are taking as blind relative risk reductions. If something's relatively unusual, 1 in a million, if we decrease it to 1 in 2 million, we've decreased it to 50% risk reduction. But is that meaningful? Now, another thing to think about is whether something is a DOE or a poem. Poems are problem-oriented evidence that matters. This is a phrase that was used by the Journal of Family Practice a number of years ago, and it was used to show those studies which really seem to have a clinical value. DOEs are disease-oriented evidence, and so we extrapolate that we're going to have changes. So we decrease sodium in the diet, it lowers the blood pressure, and we assume that it has better outcomes. The problem with this particular DOE is that we've never really been able to see a decrease in heart attacks or deaths with decreased sodium diets. It's very counterintuitive for a lot of people. They get very upset when this is pointed out to them, but it is the reality. Poems aren't going to be labeled as such. They're just going to be something that really does have an outcome that's a clinically important outcome. So in other words, it's just a study that really has a true important outcome as opposed to a proxy. A proxy is something like blood pressure or cholesterol levels, etc. Now, when we're doing evidence-based practice, you'll hear people talk about a PICO or a PICO question. These are good questions to really think about what we're looking at and what the intervention is and what the comparison is and what the outcome is. On one of the next pages, it does talk about the TRIP website, and the TRIP website will actually let you search it based on your own PICO or PICO question. So resources, www.guideline.gov is currently shut down due to lack of funding. I really hope that over the next several months somebody finds some funding. It really is a useful site, or at least it used to be. It is, I think, a huge loss for clinical practice that it's gone. Cochrane Review. Cochrane was a pioneer in evidence-based practice, and these are great reviews. Dynamed is a great website. It does have a subscription cost, so you'll have to look at that. Evidence Alerts is free. PubMed is free. TRIP used to mean turning research into practice, but then now just use the abbreviation TRIP for the website. Best Bets is kind of an older site, still has some good stuff on it, but is somewhat falling out of date. Up to Date, I have mixed emotions about. I think it's really good information if you need something quick and dirty. The problem is that a lot of the stuff on Up to Date is opinion. They pretty much clearly identify when it's opinion, but a lot of it is opinion. So just be careful when you're reading it not to say, well, Up to Date says, when you're citing the opinion as opposed to the actual research and evidence-based information. eMedicine is a free website. It's basically part of another website called WebMD. It's the professional version. It's actually pretty good stuff. It's very up to date. I think it's 95% as good as up to date, and it's free. So All right, well, this gives you a little bit of information. This is just a very brief intro to evidence-based practice, and obviously we'll continue to talk about evidence-based practice throughout the rest of the program.